Good afternoon, and dear Dr. Namrata, thank you so much for this opportunity to be in the company of such august people, and after such, and after such lovely talks, let's go to another set of situations which also exist, and once in a while, either because of our overconfidence or because of carelessness, we may land up with some of these situations. And there are some situations which you either guess or you know obviously that need to be taken care. But as part of cataract surgeon, as our volume goes up, all these situations do come, and you obviously cannot say no. And those are PCR and zonular dialysis or subluxation. And PCR is something which I think everyone has to live through. Now, what are the predisposing factors for the occurrence of PCR? They could be of multifactorial, they could be patient-related, surgeon-related, intraoperative, or machine or device-related as well. The general factors could be extraocular or intraocular. There could be various reasons. It could include a demented patient, a deep set eye and all those, or it could be reduced workspace or your uncomfortable position in which you are sitting, or it could be eye related. But the surgeon related are either we are inexperienced surgeon or we still need to go through that learning curve or high volume camp surgery. And the most important are intraoperative, where either I have made a small rhexis or the rhexis has caused a bit of tear, or when I'm doing phaco, maybe the fluid imbalance. Now this is a classic example of something I didn't expect to happen, nor you would. A normal hydro, you see that snap sign? And that spells it, you know. Now, what happens as a surgeon when you're operating, you're concentrating somewhere else, and your video cannot make that mistake. But by now you know that yes, you are in for disaster, but that was done some years back. Today I would not do it this way. I would stop, inject enough amount of viscoelastic between the rhexis and the nucleus to literally load it behind, so there's no question of the nucleus dropping, and here I'm just waiting for. And then what best can you do? You can only clean up whatever you can, and clean up you must, because I know by now I'm not like many of these who are also VR trained, but I have the benefits of VR surgeon operating in the next theater. So I just go ahead very meticulously without any expressions, because patient, since everything is closed, his eyes are open. He's listening to everything that you talk or you express. You do your case as normal, put in your lens, obviously a 3-piece lens, and if you are fortunate to have done a small rhexis, the lens gets captured, and then quietly the patient is shifted to the next theater. Now, what are the factors in decision making? It could be the extent of posterior capsular tear, whether you hyaloid face or intact or no, the location where exactly is the nucleus at that time, confidence of the surgeon, and all these things go in to finally give you that end result as normal. When it comes to nucleus or nuclear fragment management, if you have already caused PCR, where are you going to keep that nucleus till rest of the situation is created? Either you tumble it out, you use different posterior assisted levitation, or if you think it's beyond you, you convert. Now let's look at this case. You have to be attentive, and luckily on that day I was attentive, and I'm sure most of you would always be. Now it's a normal case, a normally done hydrodissection. I start with the case and watch it, Now I had it. Now why did I have it? That's because my settings were not okay. But then I was watchful. What I do, I come out, rotate the nucleus, get enough amount of viscoelastic and inject it behind. Now that is your saving grace. You know, you find the excess, you find the gap, inject viscoelastic, and then best thing you do is use two instrument technique, rotate it out and get the lens on top of the bag. Once your lens is supracapsular, then half your battle is won. Then you have various techniques. Here, in fact, I tumble it and then inject some more viscoelastic so that I have a nice cushion underneath and above. And then thanks to our friend, I also joined the bandwagon of scaffolding, and now you are bold enough because your rhexis is intact. Even if the leading haptic is, whether it's in front of the iris or behind the iris, as long as it is not, you know, behind the capsule, I mean behind the tear, you're just okay with it, and just go about your phaco in the normal way. And then it's just a matter of routine because it's not a hard nucleus. And once you have done with that, based on how much of vitreous is disturbed, how much of cortex is behind, you decide whether you want to go pars plana or you want to go from anterior. But one thing one should remember, that our causing vitrectomy from the anterior approach is not causing more disturbance to that vitreous, which we have already caused it. And a little bit of vitrectomy and I just, you know, one after another can definitely help you come out of this. And finally in this, to cut the time, you know, you reach a stage where practically most of your cortex is out and the lens is well centered, and that's it. Then we come to the next situation, which is zonular weakness. Now one has to remember, even before you manage it, what has caused it, how much is the degree of zonular loss, what's the location, because that decides where your incision is going to be, and presence or absence of vitreous decides the prognosis and the extent of work that you need to do there. And that zonular weakness could present you in various different degrees. It could be just a shallow anterior chamber despite normal axial length. It could be very focal iridodonesis. It could be visibility of peripheral lens equator upon lateral gaze, or it could be as wide as a decentered lens. But the principle one must remember is you shouldn't cause worsening of the existing defect, and if possible maintain a capsular stability in short term as well as long term. And we know that we use all these different devices, intraocular devices, for doing it. And timing and choice of insertion is also important, like the hooks and all can be inserted even before completion, whereas CTR can only be put after it. When it comes to incision, it has to be 90 degrees away from the place of weakness, and the rhexis has to be begun with a sharp tip, because as it is the entire cataract is unstable. When it comes to choice of capsular bag support based on degree and how nicely you have done it, either it can be done enough with CTR alone, or it could be scleral fixation, or various ways of fixing the lens. Now this is a situation where the defect looks quite huge, but the saving grace for me right from the beginning, even before I started, was there was no phacodonesis. It was long standing, but there was a lot of anterior capsular fibrosis, so I had to do rhexis either with Zepto or with Femto. Zepto suits me, and the reason you do that is with anterior capsular fibrosis, doing rhexis even in a normally supported capsular bag is difficult. In such cases, it's more difficult. And then once, and fortunately the nucleus wasn't hard, so once the ECR is in and the bag quite looks stable, and with the lens in, it takes normal position. At the most what you do is, because of that traumatic mydriasis, you may take one, this, I'm done, okay, with one pupilloplasty suture, your pupil is come well in it. I'll only take half a minute, ma'am. Now this is an extensive weakness and subluxation where there's vitreous as well in the anterior chamber. First thing you do is to do anterior vitrectomy, start your axis away, and then even before anything else done further, do a copious hydrodissection, free the nucleus from the back, and if possible free the epinucleus and the cortex from the back, and put in your hooks. And after that, maybe this is a stage when you do a rehydro and then put in your endocapsular ring. But that's not enough because this bag has got severe phacodonesis, and that's a time when, okay, I'm done. Then you come by way one of the various different techniques. Here I'm using Hoffman, and then there are different ways in which, and in this case you'll see me using hammer segment with the convexity out, and once the bag is fixed you will put a lens, and that's it. And thank you so much. And in conclusion, I'll tell you, when everything you think has gone right, it's 10 seconds, ma'am. Everything seems to be okay, and the patient has got trifocal in one eye, the second eye is getting trifocal, and look what happens. So that means you cannot be sure till you have left the theatre or the patient has left the theatre. The lens is about to go into a inflated bag. The cartridge gets stuck. So surgeon tries to get the lens back and forth, creates suction, and the entire bag is sucked up. So with this, what I wish to tell you is, nothing is complete till the patient has gone out of the bed and out. Thank you so much.
Thank you so much for